Hello, everyone, and thank you for the invitation to be part of this meeting. And the title of my talk is Combining Oral Anticoagulant and Antiplatelet Agents for Patients with AFib and PCI. When and for how long? These are my disclosures. So the topic of patients with atrial fibrillation and PCI and how to manage the antithrombotic therapy in these cases is really relevant because there are millions of those patients all over the world, and we need to be able to know how to manage those patients. The problem is that the STANS trials, the ACS trials did great development in antiplatelet agents, but excluded patients who also have AFib and required oral anticoagulants. And the AFib trials did great job in developing new drugs, proving new concepts for NOACs, but also excluded patients with a recent PCI and ACS. And therefore, this gave us a gap of patients who had an indication for oral anticoagulants, but also for dual antiplatelet therapy, and were never included in the major trials. And if we could summarize the problem, here's the summary. We need to use dual antiplatelet therapy to prevent stent thrombosis, myocardial infarction, recurrent ischemia. And we also have to use oral anticoagulants to prevent stroke. But when I combine those therapy in what is so-called triple therapy, my bleeding risk is exponentially high. And the bad news is that there is no way we can treat the stent thrombosis, the MI, the stroke, and the bleeding at the same time. Well, if that's not possible, what's my goal? My goal is to find the sweet spot, is find the combination of drugs that can give me the greatest net clinical benefit. But finding that sweet spot is not easy because, as you can see, there are so many drugs, different doses, different durations of combination, and different stents that today we have about 2.8 million ways to treat these patients in clinical practice, and it's impossible for any guideline to contemplate all these options. Well, to overcome that barrier, our goal then it needs to be to perform the trials and test a few of those options and give us some evidence-based guidance on how to treat these patients. And that's what we did in the last 4 years. There are 4 important trials. They are different among themselves. They tested different drugs, different doses, different durations of treatment, different treatment strategies, different trial designs, and even different inclusion criteria. The one thing that they have in common was the comparator. All these trials compared against warfarin, aspirin, and clopidogrel because that's the standard of care, or it was the standard of care. So again, it's important to keep those differences in mind so we can put the results into perspective. The Augustus trial is really unique because it's the largest trial and have this 2x2 factorial design that allow us to answer 2 important questions. First, about the NOAC, in this case, apixaban 5 milligrams twice daily, is it safer than warfarin? And second, in a double-blind fashion, the aspirin question, is it safe to drop aspirin? And when we look at the apixaban question, we found that apixaban reduced bleeding by 31%, highly statistically significant, irrespective of aspirin use. And we also saw that aspirin, irrespective of the anticoagulant that was used, increased bleeding by 89%. And if we flip those curves around, we find that aspirin reduced bleeding, avoiding aspirin, reduced bleeding by 47%. So really important. If we avoid aspirin, we're gonna save or reduce bleeding by 47%. And here we can see the 4 curves of the 2x2 factorial design, and we can appreciate that the lowest rates of bleeding we're seeing among patients assigned to apixaban without aspirin. In other words, just apixaban plus clopidogrel give us the greatest bleeding reduction. Whereas warfarin plus aspirin plus clopidogrel, the classic triple therapy, has the worst bleeding rates. However, it's important to look at ischemic events as well, which is the other part of the equation. And when you look at apixaban versus warfarin for death or ischemic events, we find no difference. on the composite endpoint, but we did find 50% lower rates of stroke in patients assigned to apixaban. And that's very much in agreement what we have shown already in the Aristotle trial in 18,000 patient study. However, when you look at aspirin and placebo, we found that patients who did not get aspirin actually had numerically higher rates of stent thrombosis. So giving some concerns about dropping aspirin instead of dropping aspirin in terms of increasing potentially the number of stent thrombosis. So we needed to look at in more details, and that's what we did. And we first found that stent thrombosis is a rare complication. Less than 1% of patients had stent thrombosis in the entire trial. And more importantly, when stent thrombosis occurred, it happened in the first 30 days. And that's a very important message because it helps us to tailor the treatment of patients with AFib undergoing PCI. And when you look at the four curves of the trial, for bleeding, as I mentioned before, apixaban plus clopidogrel was the best strategy. But for stent thrombosis, the best strategy, as highlighted in red, is actually apixaban plus aspirin plus clopidogrel for 30 days. That is what we're going to save most of the stent thrombosis. But we wanted to look at more than just stent thrombosis. So we recently presented and published these results, which is a very interesting and important analysis where we combine on the left bad bleeding events, fatal bleeding, intracranial hemorrhage, major bleed, and on the right, bad ischemic events, CV death, stroke, MI, and stent thrombosis. In the first 30 days, we can appreciate that aspirin increased bad bleeding events in the same proportion that actually reduces bad ischemic events. So in almost now 1-to-1 ratio, aspirin caused bad bleeds and saved bad ischemic events. So that helps us in terms of making decisions if you want to keep aspirin a little bit longer for 30 days, if the risk of ischemic events is very high and the risk of bleeding is not very high. After 30 days, as we can appreciate here, aspirin continues to increase bleeding risk, but now has no effect whatsoever on ischemic events. So very important analysis because it helps us to tease out and further tailor the duration of aspirin for at max 30 days in selected patients. If we put all these in a meta-analysis, that's what we recently published, a network meta-analysis of all the 5 trials in the field, which give us about 12,000 patients worth of data, testing 4 regimens. That's why it's a network meta-analysis, because it's testing 4 regimens. Triple therapy with warfarin, triple therapy with a NOAC, double therapy, no aspirin with warfarin, double therapy, no aspirin with a NOAC. And we can appreciate in the upper part of the slide that for bleeding, no question that the safest regimen is the NOAC plus a P2Y12 inhibitor without aspirin. And for ischemic events like myocardial infarction and stent thrombosis, there was basically no difference among the 4 regimens. So the conclusion of this meta-analysis is that in patients with AFib undergoing PCI, a regimen that includes a NOAC plus a P2Y12 inhibitor is associated with the best bleeding rates, the lowest bleeding complications, including intracranial hemorrhage, without any significant difference when in ischemic events when I compare with vitamin K antagonist plus dual antiplatelet therapy, the classic triple therapy. So what's the present/future of this topic? Well, we learned that in the acute phase, we're going to use everything we normally use. The P2Y12 inhibitor, aspirin, heparin, 2B3 inhibitors in some cases. But once the patient is stable, we're going to, by the time of discharge, around 5 to 7 days, we're going to prescribe a NOAC in the appropriate dose, plus a P2Y12 inhibitor that can be clopidogrel for most cases, and stop aspirin. That should be the default. We also learned that regimens that include vitamin K antagonist plus aspirin plus a P2Y12 inhibitor, the classic triple therapy, should generally be avoided because we just basically increase bleeding risk without any benefit in ischemic endpoints. We also learned that if the risk of stent thrombosis and other ischemic events is very high and the bleeding risk is acceptable, maybe using aspirin a little bit longer for 30 days sounds reasonable. Now, guidelines are more in agreement among each other because they are using data instead of people's opinion. And we are now seeing more level of evidence A on those recommendations in general guidelines. Remember, we also learned that after 12 months, the default should be anticoagulants alone because adding antiplatelet therapy chronically for these patients mainly increase bleeding risk without significant benefit on ischemic endpoints. And as I mentioned, there are 2.8 million ways to treat these patients. We studied four of them. If there are many others, and if we really want to know if other options can be used, the best way to do that is to test them in a randomized trials. So this is our goal, antithrombotic sweet spot. If we find the sweet spot, we give the best to our patients. And how do we find that? Look at every patient characteristics, every PCI characteristic, and then based on that, choose the right drugs at the right doses for the right durations that can give us the greatest reduction in ischemic events at a minimal cost of bleeding, which is never zero. But if I can minimize bleeding while I preserve the efficacy, then I found the sweet spot, and therefore I can provide the greatest net clinical benefit to our patients. Thank you very much for your attention.